Imagine trying to prove that something didn't happen.
Right.
Not just yesterday or last week, but over the last 15 years, across 3 totally different countries involving, hundreds of thousands of individual people.
It's a massive scale.
Yeah, and that is the murky, honestly almost impossible diagnostic landscape of long-term preventative medicine.
It really is the ultimate waiting game.
Yeah.
Because when you introduce a medical intervention across a population...
Especially for a disease that takes decades to develop.
Exactly. You don't get immediate gratification. You don't get a clean, instant result on a spreadsheet. You just get 15 years of silence, hoping the data eventually tells a story.
Which brings us to the focus of today's deep dive. We are looking at a truly fascinating new target trial emulation study on the long-term effectiveness of the human papillomavirus vaccine.
The HPV vaccine, yeah.
Right, the HPV vaccine. And we have a vast stack of sources here looking at what actually happened after the very first public vaccination programs launched in Europe back in 2008.
Which was a huge milestone.
Oh, for sure.
Yeah.
We are talking about girls who were age 15 and younger at the time getting this novel vaccine, and then, well, everyone just had to wait.
And waiting 15 years is a critical milestone in this specific field. I mean, it's enough time for individuals who were vaccinated as kids or teenagers to reach an age where we might typically start seeing the development of the precancerous conditions.
Or the actual diseases the vaccine is designed to prevent.
Precisely.
So the mission for this deep dive is to unpack exactly how well this unprecedented multinational public health initiative has performed in the real world over a decade and a half. We are specifically looking at how it impacted rates of invasive cervical cancer and high-grade precancerous lesions. Okay, let's unpack this. Because we always hear about vaccines being tested in pristine labs, right? With perfectly controlled clinical trials.
Always.
But how do you actually measure if something stopped a cancer from developing over the course of 15 messy, totally unpredictable years of human life? Because people move, they change doctors, diets change, they forget to go to the clinic. How is this even possible to track?
It is a monumental challenge, and you really cannot do it with a traditional study. To figure this out, the researchers utilized something called a target trial emulation study using primary care databases.
Which sounds like a simulation almost.
In a way, it is. Because think about a traditional randomized controlled trial. You take a group of people, you randomly give half of them the vaccine and half a placebo, and you watch them.
Right.
In a highly controlled artificial environment for a few months or maybe a few years. But you cannot, realistically or ethically for that matter, do that for 15 years across entire populations.
No, of course not.
You can't just tell a control group of teenagers, hey, don't get this preventative vaccine for the next 2 decades, just so we can see what happens to you.
Right. That would be completely unacceptable.
So a target trial emulation essentially works backwards. It uses sweeping amounts of real-world, already existing medical data to recreate or emulate the conditions of a randomized trial.
Totally after the fact.
Exactly. Entirely after the fact.
So to understand the results we are going to explore today, for anyone listening, you really need to understand the sheer scale of the time machine these researchers had to build.
Yeah, time machine's a good way to put it.
Because they needed to pull together 15 years of medical history, and they didn't just do it in one town or one hospital network.
No, they looked at 3 different European countries, each with their own distinct healthcare systems and, their own data-keeping habits, their own registries.
Which sounds like a logistical nightmare.
Oh, absolutely. First, they pulled primary care records from the UK using the Clinical Practice Research Data Lake. And this database is a goldmine, because it actually had data stretching from September 1987 all the way to December 2023.
Wow. Decades of doctor visits just sitting in a database. I mean, every cough, every screening, every prescription.
Yeah. Then they went to Catalonia, Spain, using a system called CityApp, pulling records from January 2006 to June 2023. And what makes the Spanish data so crucial is that this database linked primary care records directly to hospital records.
Okay.
So it's not just what happens in the local clinic, it is what happens if the patient needs surgery or specialized care.
So you really get the full journey of the patient.
Precisely.
Okay.
And finally, they used the Norwegian Linked Health Registry, analyzing data from January 2018 to December 2023. Norway has incredibly comprehensive health registries,
Right.
linking primary care, secondary care, and other health data nationwide. It is a highly integrated system.
So hold on, let me make sure I'm visualizing the reality of this. A primary care doctor in a London clinic in 2010 is definitely not writing down medical codes the exact same way a specialist in Oslo is in 2020.
Not at all.
In the UK, a doctor might code a screening as one specific alphanumeric tag, while in Norway, it might be a completely different text note in a different language. How do you even combine that data without it turning into complete static?
Well, that is the harmonization challenge, and it is where the methodology gets brilliant.
Yeah.
They standardized all of these disparate localized records across the 3 countries using something called the Observational Medical Outcomes Partnership Common Data Model,
Okay.
or OMOP.
Oh, MAP. So how does that actually work in practice?
Think of it as a universal translator for medical records. It basically strips away the local language, the regional formatting,
Oh, that's stuff.
right, the specific software codes of individual clinics. It takes all that messy data entry and converts it into one single standardized digital tag.
Oh, wow.
So whether a doctor in Spain typed in a specific regional code for a cervical screening or a nurse in the UK clicked a specific drop-down menu, the OMP model translates both actions into the exact same standardized data point.
That's incredible.
It allows researchers to compare apples to apples across borders. If we connect this to the bigger picture, standardizing multinational health registries into one cohesive dataset is a staggering achievement. We are talking about millions of individual, highly complex data points spanning over a decade, all being harmonized so they can finally talk to each other.
And once they have the data speaking the exact same language, they have to actually define who they are looking at, right? The study defined the exposure group as women who received 1 or more HPV vaccine doses by the time they were 15 years old.
Correct.
But you can't just compare them to a random sample of the public, right?
No, definitely not, because a random sample introduces too many variables. They utilized a sequential matching process. Every single year of the study period, they matched up to 5 vaccinated individuals to 1 unvaccinated individual.
And how did they pick them? Just out of a hat?
No, they matched them by year of birth and location, but most importantly, by something called propensity scores.
Okay, let's break that down. Because propensity scores sound like something out of a behavioral psychology textbook. What actually goes into a propensity score?
A propensity score is essentially a statistical summary of how likely a person was to get the vaccine in the first place, based on all their other measurable traits.
Like what?
It factors in underlying health conditions, socioeconomic status indicators, how often they visited the doctor in the prior year, and any other available health markers. The algorithm hunts through the database to find an unvaccinated person whose health profile perfectly mirrors a vaccinated person.
Oh, I see. So it's like trying to find the most valuable baseball batter, but instead of setting up a new batting cage and testing everyone today, you just feed the last 15 years of box scores into an algorithm.
That's a great way to think about it.
And you mathematically match up players who face the exact same pitchers in the exact same stadiums, in the exact same weather conditions. You computationally eliminate every outside advantage, so the only real difference left is the swing itself.
That is the perfect way to look at it. They are statistically isolating the vaccine. And once they had these perfectly matched pairs, they used a statistical tool called Poisson regression to calculate the incidence rate ratios after those 15 years of follow-up.
Poisson regression. Okay, let's apply the explain it to me like I'm 5 rule here.
Fair enough.
Yeah.
Because we are looking at events happening over a very specific, long time frame, 15 years. Poisson regression acts almost like calculating the speed limit of a disease.
The speed limit.
Yeah, it doesn't just ask, did this happen? It calculates the rate at which these precancerous lesions are appearing in one group versus the other over that exact period of time. It basically measures the velocity of the disease.
Got it. So they've built this incredibly precise multinational data machine. They've matched the players. They've set up the speed cameras.
Right.
But the irony of science is that sometimes the more precise your machine is, the more it exposes the flaws in your original question, which is exactly what happened when they finally turned this thing on. Here's where it gets really interesting.
It does.
Because they hit a giant scientific hurdle that forced them to change their entire plan in the middle of the study.
Yes, the protocol pivot. It is a crucial part of understanding how real-world long-term science actually operates when it hits reality. The original protocol, the initial blueprint for this study when it was first conceived, had a very specific primary analysis in mind.
Right.
They wanted to assess the effectiveness of the vaccine by looking at the specific brands of the HPV vaccine that were administered.
So they wanted to know if brand A was performing better out in the wild than brand B, or if one specific formula was doing the heavy lifting.
Precisely. They wanted to compare the outcomes of those specific brands against the unvaccinated populations. But when they actually ran the standardized numbers, they realized the study was drastically underpowered for that specific goal.
Wait, my alarm bells are ringing here.
I'm sure they are.
Because you hear about researchers changing the primary goal in the middle of a study, and it sounds like the definition of bad science. If you set out to study brands, and then you change the rules halfway through, doesn't that make the results look like you are just fishing for a conclusion?
In some contexts, yes. Changing endpoints after you see the data is a massive red flag. It's called p-hacking.
Right.
But you have to look at the mechanics of why they changed it here. This wasn't an attempt to hide bad results. It was an unavoidable mathematical reality. Underpowered in statistics doesn't mean the data was bad.
What does it mean?
It simply means you don't have enough events, in this case, enough instances of actual disease to draw a mathematically sound conclusion.
So they literally couldn't compare the brands because not enough people were getting sick?
Exactly. Just think about the math. If you only have a tiny, scattered handful of cases of precancerous lesions across hundreds of thousands of women, and then you try to divide those few cases up into even smaller buckets based on which brand of vaccine the patient got 15 years ago, the numbers become microscopic.
You end up comparing like 3 cases to 4 cases.
Right. And at that level, any difference you see could entirely be random chance. You lose the mathematical power to confidently declare that brand X is better than brand Y. The noise just completely overwhelms the signal.
Oh, wow. That is effectively a good problem to have in public health. You are failing to compare the brands because your population is too healthy.
It is the best problem to have. And it highlights the rigors of scientific honesty. They had to publicly admit that they lacked the statistical power for their original, highly specific claim. They couldn't ethically publish a comparison of brands because the data simply could not support it without being misleading.
So they adjusted the lens.
They amended the primary analysis to assess overall HPV vaccination exposure, meaning any brand of the vaccine bundled together versus the unvaccinated group. They adjusted their question to match what the sheer volume of data could actually reliably answer.
Because you can't squeeze statistical significance from a tiny pool of sick patients.
Exactly.
So having established this final rock-solid methodology looking at overall vaccinated versus unvaccinated, it is time to look at the scorecard. We need to reveal the actual long-awaited numbers that this adjusted study produced.
The sheer scale of the final cohorts is staggering, especially after that intense sequential matching process we talked about. The UK data included nearly 82,000 vaccinated women compared to over 46,000 unvaccinated women.
Huge numbers.
In Spain, the pool was even larger, over 148,000 vaccinated compared to roughly 40,000 unvaccinated. And in Norway, nearly 15,000 vaccinated against about 4,000 unvaccinated.
We are talking about hundreds of thousands of lives tracked over a decade and a half. So what did the Poisson regression actually find regarding the main outcomes? The study specifically looked at high-grade cervical intraepithelial neoplasia, which they code as CIN2 plus 2. Basically, these are high-grade precancerous lesions. They also looked at conization, which is a surgical procedure to remove abnormal tissue, used here as a proxy for a CIN2 plus diagnosis. And, of course, they wanted to look at invasive cervical cancer.
Let's start with the precancerous lesions, the CIN2++ zone. The meta-analytic vaccine effectiveness across all these harmonized databases at the 15-year mark was calculated at 42%.
Okay.
And against the conization surgery, the effectiveness was calculated at 58%.
Okay. I'm looking at that 42% effectiveness against CIM2 plus gum, and I have to push back a little bit. We just spent all this time talking about building this incredible multinational time machine, harmonizing 3 different medical languages, tracking hundreds of thousands of people for 15 years, waiting for this ultimate real-world proof. And the headline number is 42%. As a listener, that sounds incredibly low for a major global vaccine initiative. Is the medical community disappointed by that?
What's fascinating here is that to understand why that 42% is actually a profound misdirection, we have to talk about a hidden psychological bias within the database itself. It's a phenomenon the researchers call the screening paradox.
The screening paradox, meaning the act of looking for the disease changes the data.
That is the core of it. The researchers explicitly noted that these estimates of 42% and 58% actually do align with estimates from previous systematic reviews of randomized controlled trials.
Oh, really?
Yeah, the vaccine is performing biologically exactly as those pristine controlled trials predicted it would.
So why does 42% feel so underwhelming on a real-world spreadsheet?
Because of human behavior, the researchers identified a clear pattern of increased health-seeking behavior among the vaccinated individuals.
Health-seeking behavior, meaning how people act outside of just taking a pill or getting a shot in the arm.
Yes, think about the demographic. The researchers observed that the kind of person who gets the HPV vaccine, or whose parents ensure they get it right at age 15, is generally more proactive about their overall health.
That makes sense.
They are more securely plugged into the healthcare system. They might eat differently, they might exercise more, but crucially, they go to the doctor more routinely. They get their preventative screenings on a regular schedule.
Because they are the kind of people who care about preventative medicine.
Exactly. Now, compare them to the unvaccinated group. If you are less plugged into the healthcare system or more hesitant about medical interventions, you are less likely to schedule a routine screening when you feel perfectly fine.
Oh, I see where the math gets skewed.
Right, because the vaccinated group is getting screened more frequently, doctors are inevitably going to find more precancerous lesions in this group. Not because the vaccine isn't working, but simply because the doctors are actively looking for them.
Wow.
The unvaccinated group might have just as many, or far more, lesions developing silently. But because they aren't going to the doctor for their routine screenings, those lesions are going entirely unrecorded in the national databases.
This is a wild concept to wrap your head around. It's like looking for typos in a massive, thousands of pages long book.
Okay, I like this.
If you give a specific group of people really strong reading glasses, which in this case represents proactive health behaviors, like getting vaccinated and going to the clinic for checkups,
Yeah.
they are going to spot a certain number of typos.
Right.
Those typos are the precancerous lesions. Now, compare them to a group of people who aren't wearing glasses and honestly aren't even opening the book very often. The people with the glasses are going to report finding way more typos to the publisher simply because they are looking closely at the pages.
Exactly.
If you just stare at the raw data of reported typos, it artificially makes it look like the reading glasses caused the typos to be found, or that the glasses are only 42% effective at preventing typos. But really, the glasses are just revealing what was already sitting there on the page.
That is a brilliant analogy.
Yeah.
The intense scrutiny artificially drives the perceived effectiveness percentage down on paper. Because of this health-seeking behavior, the researchers concluded that the 42% effectiveness against precancerous lesions is very likely a significant underestimate. The vaccine is almost certainly performing much better than that number suggests, but the psychology of the proactive patients is skewing the raw database numbers. They're basically getting punished in the data for being healthy.
The act of caring for your health actually makes the medicine look slightly less effective to the algorithm.
It really does.
But what about the ultimate goal of the 2008 rollout? What about the invasive cervical cancer numbers?
This brings us to perhaps the most profound finding, or rather lack of finding, in the entire 15-year study. Across all of these massive cohorts, hundreds of thousands of women across the UK, Spain, and Norway, there were fewer than 5 cervical cancers observed per cohort.
Wait, fewer than 5 total,
Right.
over 15 years.
Per cohort, yes. The events of actual invasive cervical cancer were so incredibly rare across the board that the researchers could not even run the Poisson regression.
You're kidding.
No, they could not estimate the vaccine's effectiveness for this specific ultimate outcome. They simply didn't have enough data points.
That is another one of those good problems. You build a 15-year time machine to measure cancer, and you can't measure it because nobody is getting cancer.
It means that to get the final, definitive numbers on how well this vaccine prevents invasive cervical cancer in the real world,
Yeah.
15 years simply isn't long enough.
Because it's too slow.
Right. The disease progression from a lesion to invasive cancer is incredibly slow. And thankfully, the cases are currently so rare in these age groups that further studies with even longer follow-up periods, perhaps 20 or 25 years, are going to be required to get that final number.
So what does this all mean? We started this deep dive asking how you measure a medical intervention over 15 messy, unpredictable years of human life. And the answer is very carefully.
Right.
With an unbelievable amount of harmonized data and a heavy, heavy dose of psychological awareness. The key takeaway for you listening is how difficult, how noisy, but ultimately how vital long-term real-world data is. The vaccine is working as expected. It is aligning with those earlier pristine clinical trials, but the real world is infinitely more complicated than a lab. We have to be patient enough to wait even longer than a decade and a half to see the ultimate final numbers on actual invasive cervical cancer purely because, thankfully, those cases are currently so rare.
This raises an important question, and it is something I really want to leave you with today.
Yeah.
We just spent a lot of time unpacking health-seeking behavior and the screening paradox.
Yeah.
We saw how the simple act of being cautious, wearing the reading glasses, and getting tested more often can artificially lower the perceived success of a major vaccine in a database. It makes you wonder, if patient psychology can obscure the data this significantly in a massive, highly scrutinized multinational study, how many other treatments, diets, or lifestyle habits throughout medical history have we completely misunderstood?
That is a fascinating thread to pull on.
How often is the data telling us a story, not about the efficacy of the medicine or the supplement itself, but about the psychology of the patient who chooses to take it? If the people who choose to eat a certain way or take a certain vitamin are also the people who naturally exercise more, sleep better, and go to the doctor for preventative care, how do we ever truly separate the medicine from the mindset? It's a reminder that numbers in a database are never just numbers. They are echoes of real human lives, and humans are wonderfully, frustratingly complex.
It brings us right back to where we started. Proving a negative over 15 years is a monumental task. You can't just look for a clean answer on a spreadsheet. You have to fundamentally understand the person who walked into the clinic in the first place. Thank you for joining us on this deep dive. Keep questioning the data around you, look for the hidden variables in your own life, and we will catch you next time.